Post tea break session will start now, and we have this session on electrophysiology, devices in arrhythmia management. And we have three speakers, Dr. Amit Vora, Dr. Ashish Nabar, and Dr. Vanita Arora. And I would like to invite Dr. Amit Vora, Dr. Saurabh Deshpande, and Dr. Malav Jhala to kindly occupy the chairs and take the proceedings ahead. Dr. Amit Vora, Dr. Saurabh Deshpande, and Dr. Malav Jhala.
Welcome back everyone after the tea break. The next speaker I don't think needs any introduction. Dr. Amit Vora sir will be talking about devices in heart failure, and he'll be speaking on CRT. Over to you, sir.
Thank you. Good morning to all of you, and I think this is a fantastic update on the newer advances that have been happening in cardiology, and now we are going to focus on electrophysiology and devices. So in terms of cardiac resynchronization therapy, it's now almost 2 decades old therapy, but a lot of innovations keep on happening in every field, and this field too. And I'm going to try and actually not go too much into what is conventionally known, but the expanding horizon and indications of cardiac resynchronization therapy in the current domain, and taking into consideration what advances have been happening in the last year or so, and the updated guidelines. So what I'll be covering up briefly is the concept of cardiac physiologic pacing. So all of these new terminologies are coming up, and I'll dwell a bit into it. What is cardiac physiologic pacing? Because that's what you're going to hear more and more, other than CRT and conduction system pacing. We all know the conventional reason for doing a cardiac resynchronization therapy using a biventricular pacing is in patients with LV dysfunction, ejection fraction less than 35%, left bundle branch block, QRS with more than 150 millisecond, and despite optimal guideline directed medical therapy for over a period of 3 months, they continue to remain in NYHA class 2 to 4. But now I'm going to talk to you about CRT, the role of CRT in patients who have an ejection fraction which is 35 to 50%, so relatively better ejection fraction. We'll talk about CRT in non-LBBB patients, certain specific conditions like pacing-induced cardiomyopathy in the female gender, and what is the role vis-a-vis cardiac conduction system pacing or using both the techniques. So let's first clarify the definition of cardiac physiologic pacing. It essentially means when a pacing is intended to restore or preserve synchrony of ventricular contraction. So how do we restore or preserve synchrony? The conventional way was by using cardiac resynchronization therapy by biventricular pacing, and the way we used to do it is through the coronary sinus, get into the left ventricular posterolateral wall and pace in the epicardial region of the left ventricle. This is the conventional way in which we achieve physiologic pacing by this biventricular pacing modality. What is upcoming in the field is the conduction system pacing. Conduction system pacing started with his bundle pacing and then have now evolved into a left bundle branch area pacing. So either of them is now clubbed under the broad heading of cardiac physiologic pacing, and cardiac physiologic pacing is going to be the future of pacing. Let's get into in a relatively preserved ejection fraction, not the 35% or less, that's a no-brainer, everybody knows about it. But when do we consider cardiac physiologic pacing in patients who have ejection fraction in 35 to 50% range? So what we need to revisit is that every patient who needs a pacemaker, bradycardia indication for a pacemaker, we should actually be asking a couple of questions, and those questions would be, what is the anticipated ventricular pacing going to be? if it is going to be significant, substantial ventricular pacing, as we call it, more than 40% of the times he is going to pace in the ventricles, and that will happen with all AV block patients. So all AV block patients, ventricular pacing is going to be definitely much more, almost 100%. In all these patients, the next question to ask is, what is the ejection fraction? Now, if the EF is in the range of 50% or more, then you can continue doing your conventional dual chamber pacing the way you are going to do for this bradycardia indication. But if you have an ejection fraction in the 35 to 50% range, there is sufficient data accumulated now to say that cardiac resynchronization with biventricular pacing is a class 2A indication, and also a left bundle branch area pacing is evolving in this area. It could also be done. So this background knowledge came up essentially with the block heart failure study that was done, and that showed that when you compare RV pacing with biventricular pacing in these patients who have ejection fraction less than 50%, and the indication is just a bradycardia pacemaker indication, you can see that the quality of life score is significantly better at all times. Immediately on a follow-up 1 month to up to 2 years, you see that the biventricular pacing arm in these patients with ejection fraction between 35 to 50% do significantly better as compared to RV pacing alone. So that is the knowledge we have gained, that even in relatively preserved ejection fraction, it might be worth considering biventricular pacing or a conduction system pacing. What about the non-LBBB patient? I think the best responder comes with typical LBBB with a QRS width which is more than 150 millisecond. But unfortunately, we are faced often with cardiomyopathy patients who don't have the typical LBBB. They have interventricular conduction defect, RBBB with left axis deviation, and they are also with optimal guideline directed medical therapy also, they are not doing too well. What options do we have? And therefore, various trials in the past have had small group of these patients where it is not an LBBB morphology, and when they have been retrospectively in a pooled analysis evaluated, it's been found that those with non-LBB morphology but EF less than 35% with a wide QRS of more than 150 millisecond, and if they are in NYHA class 3 or 4, CRT with biventricular pacing seems to do good even in this group of patients. So it's a reasonable thing to do. It's a class 2A indication to consider in these group of people as well. And let me show you one example that, often we do pooling of things. When you have a non-LBBB kind of a patient and you want the maximum benefit to come, you know that pacing only with CRT with a corny sinus lead might not yield that result because it's not a typical LBBB. So why don't we combine it with left bundle branch area pacing? And that is what we call as left bundle branch area optimized CRT. So you do a left bundle branch area pacing and conventional CS lead being put, and this is called a LOT CRT. A LOT CRT is something which also works well. So a patient who does not have a typical LBBB but very wide QRS with the combination of left bundle area pacing and the CS pacing in the LV epicardial vein, you get a reasonably good narrow QRS, and that is likely to be reflective in terms of improvement in LV function and overall clinical status. What about females? We know that amongst the responders to CRT, non-ischemic dilated cardiomyopathy, LBBB, wide QRS, these are the ones that respond well. Even females respond much better than males in terms of CRT. And what is interesting to understand is that if you look at various QRS width, less than 150 to more than 150 millisecond, and the clinical outcomes of heart failure or death, you find that the female gender tends to do better even if the QRS width is less than 150 millisecond. In men, it is almost always more than 150 millisecond, but in women, even less than 150 millisecond, they tend to do well. One should understand that all the CRT trials, women are little underrepresented. Only 20-30% are women, rest all are men. But whatever retrospective data we have, we find that they do tend to do better. So it's become a class 1 indication even with an LBBB when a QRS width is 120 to 150 millisecond as per the updated guidelines. I would be a little cautious in taking up 120 millisecond, and I would refrain myself between 130 to 150 millisecond for the simple reason that between 120 to 129 millisecond, the number of patients have been really small in number for us to draw a meaningful conclusion. But this brings up the interesting concept. Why do women do better as compared to men? And probably there is an anthropometric reason for it. And this is a nice depiction that this tells you about the QRS width, and this tells you about the height of the patient. So the light blue are the ones which do better. So we realize that once you have 150 millisecond QRS, everybody does better. But in the QRS width, which is in the 120 to 150 range, those who are of a smaller height tend to do better. And that's probably one of the reasons why women tend to do better. And therefore, in the Indian context also, it might be so, it's not been analyzed, but it's a thought-provoking thing that maybe a relatively narrower QRS also might have a better outcome. The other thing is in the concept of pacing-induced cardiomyopathy. Now, this is something which we need to realize and understand. How do we define pacing-induced cardiomyopathy? If there is a 10% or more decline in the ejection fraction with pacemaker, when the baseline ejection fraction was known to be more than 50%, and there is no other obvious explanation for the drop in ejection fraction, we would consider this as a pacing-induced LV dysfunction or pacing-induced cardiomyopathy. And this pacing-induced cardiomyopathy is not only just figuratively LV dysfunction, but translates into clinical heart failure symptoms also in some group of people. And the prevalence in various studies have been different because, it's a multifactorial thing, and therefore there are various other variables which can affect the development of pacing-induced cardiomyopathy. But generally one would say that up to 20% of patients with a conventional dual chamber pacemaker in a conventional RV lead location are likely to develop pacing-induced cardiomyopathy, which will require an assessment over a long period of time. So the guidelines for pacing-induced cardiomyopathy state that in such a situation, if you have a CRT with a biventricular pacing is a class 1 indication. So if you have a pacing-induced cardiomyopathy, and similarly you have all other criteria met, that you have NYHA class 2 to 4, despite optimal medical therapy continues to be in NYHA this class, then you can consider CRT with biventricular pacing and a conduction system pacing as a class 2A indication. Now, the other aspect about CRT is that there are few things technically while the implant is being done. One is that now we have almost certainly moved to quadripolar pacing lead. So now we rarely do a biventricular pacing with a bipolar lead. Quadripolar lead affords or gives you the flexibility of pacing from various different locations. In fact, there would be almost a 16 permutation combination. So therefore, the responder rate, the programmability and the responder rate can increase with a quadripolar pacing lead. And of course, that also allows you multi-site pacing. So multi-site pacing would mean that in that quadripolar lead, you're not using one bipole only, but probably using two bipoles so that you can have a wider capture of the left ventricle that can translate into a better outcome. So quadripolar lead is class 1A indication. And what is important is not to use an apical location for left ventricular pacing. That is important. Apical location uniformly does bad. You have to have more basal or mid location that does the best. And while you are implanting, you try to program in a manner which gets you the maximum narrowness of the QRS width with pacing, and that works very well. So this is important, and I think I'll just quickly wind up saying that the conduction system pacing, which Ashish is going to talk about, is now also often used when you have a failed biventricular pacing modality. So here we were doing a biventricular pacing, one vein, but the threshold phrenic nerve stimulation, everything was very high. So eventually we went ahead and put a left bundle branch area pacing, and that worked very well. The QRS with RV pacing alone, which was 170 millisecond, came down to 125 millisecond or so. So it works very well. As far as adding an ICD is concerned, clearly if it's an advanced age, CRT-P alone may be considered, but myocardial scarring and fibrosis is the reason why ICDs get added to CRT-P. But yes, you look at various other factors like non-ischemic cardiomyopathy and stuff like that, where you expect a better responder rate, you may consider this. So let me sum up by just highlighting few other random points. That periodic assessment of all pacemaker implanted patients should be done to identify pacing-induced cardiomyopathy. Patients with left bundle branch block also should be followed regularly to have identified dysynchrony-induced cardiomyopathy. And left bundle branch block patients requiring a conventional dual chamber pacing for AV block reasons should be considered for a biventricular pacing or a conduction system pacing. Even surgeons, when they do bypass surgery in select group of people, you might ask them to put a left ventricle lead if there's a pre-existing LVBB and LV dysfunction. Atrial fibrillation with rapid ventricular rate or the ones with LVBB and LV dysfunction may also benefit from this technique. I will stop here. Thank you very much for your patient listening.